further delay, I would like to welcome Dr. Kabindra Bajracharya on the behalf of Mero Eye Foundation and audience. Over to you, sir.
Thank you, Dr. Aprina ji, and thank you, Kapil ji and Ananta, for this wonderful time to present on one of my usual practice related with the strabismus in pediatric population. I will go to my presentation now. So today we will be briefly talking about strabismus introduction, its classification, evaluation, and treatment, both non-surgical and surgical treatment. So strabismus means ocular misalignment, whether caused by abnormalities in binocular vision or by anomalies of neuromuscular control of ocular motility. It is condition when visual axis, the line joining fovea, nodal point, and object of regard of both eyes do not meet at the point of fixation. It is nearly 2% in the childhood population. There are several classifications for strabismus. On the basis of fusional status, it can be orthophoria, which is actually the ideal ocular alignment and seldom encountered. Heterophoria is latent strabismus, where ocular deviation is kept latent by fusional mechanism. It can be esophoria, exophoria, right and left hyperphoria, right and left hypophoria, and encyclo and excyclophoria. So heterotropia is manifest strabismus, where fusional mechanism cannot kept control and it is manifested. So it is either exotropia, esotropia, right or left hypertropia, right or left hypotropia, and encyclo and excyclohypotropia. Intermittent tropia is a condition where fusion is controlled part of the time. So sometimes eye looks aligned, sometimes it's squinting. So here we can see the normal state of eyes. Both eyes are looking parallel in the upmost, esotropia in the second one, exotropia right eye, the third one, and fourth and fifth one, there are hypotropia and hypertropia. So again, this exotropia right eye, left eye, and the left eye again, esotropia with slight inferior oblique overaction over the left eye. So depending upon the angle of the gaze changes, and there is a difference in deviation, it can be committant or concomitant type, and incommittant or there is a very less deviation in prism in different gazes, whereas in incomitant type, the prism diopter changes with different gazes. And in it also, paralytic and restrictive can be the subtypes. So these are a few pictures who visited Lumbini Eye Institute. The first picture being is third knob palsy. The second picture, left eye, sixth knob palsy. And the third picture is left eye, superior oblique palsy. Depending on the basis of fixation pattern, it can be alternating, where there is a spontaneous alteration of fixation from one eye to the other, and monoocular, when there is definite preference for fixation with one eye. And on age of onset basis, it can be congenital or infantile, where deviation is documented before 6 months of life, and acquired is later onset after a period of normal visual development. So again, it can be horizontal, vertical, torsional, and combined. Sometimes we encounter pseudo-strabismus, where actually eyes are aligned, but it seems to be iso, like pseudo-iso in case of epicantic fold, pseudo-exo in case of telecanthus, like that. It is brief introduction and classification of strabismus. Now we'd like to talk on the management of strabismus in childhood. It is multidisciplinary approach. It involves children, parents, ophthalmologist, ophthalmic assistant, orthoptist, optometrist, and pediatrician. It is the combined work. And it is not one-time procedure, but requires long-term commitment for successful treatment. So management consists of evaluation and then the treatment part. Coming to strabismus evaluation, we will talk briefly about the history taking, then the test, and then ocular examination. In history, the history of deviation should be documented, age of onset, it is constant or intermittent, it is present in distance only or near only, or in both, is unilateral or alternating, present in inattentive and fatigue stage only or always present, and history of diplopia. Also, treatment history is important regarding use of glass, patching, orthoptic therapy, and ocular surgery before. Birth history is important. The maternal history during pregnancy, and the time of birth is premature or term. The family history of strabismus is also important. History of trauma to the eyes and head is also important. And we should consider the previous old photographs to compare for the degree of changes in strabismus, and is it acute onset or present from congenital or at birth. Now coming to the test, visual acuity is always important. Because if vision is not good, the eyes are definitely going to turn inward in case of small children. So visual acuity test, in case of children, we can use fixation behavior like central steady maintain, visually evoke potential, preferential looking chart, occlusion alone can also be significant to see either the eye is having vision or not. For 2 to 5 years old preschool, alien pictures, K chart, HOTV chart, illiterate e-test can be useful to assess visual acuity. And 5 years and more, Snellen's and Logmar acuity test can be used. Assessment of ocular alignment. Light reflect test, Bruckner test is one of the important tests which is done on pre-dilatation in dim room with examiner sitting at 1 meter from patient, and direct ophthalmoscope shine both pupil and see the color difference. If both are the same color with red reflex, then the eyes is orthotropic. Otherwise, if color is bright, white or yellow, then we have to think that eye with brighter reflex is deviating in and out, in or out. So here we can see the right eye is normal red reflex, whereas left eye there is bright reflex and the eye is isotropic. Then examination of case of strabismus, begin with inspection. Large degree of squint is obvious on inspection. We have to look for any abnormal head posture like chin up, down, for hypertropia, face turn for sometimes the lateral rectus palsy, Duane's retraction syndrome, heel tilt, usually vertical strabismus, as in case of superior oblique palsy. And facial asymmetry is also important in case of superior oblique palsy. And then we have to examine the extraocular movements, both uniocular and binocular, the movements, and 6 cardinal gaze of movements are very important. So we'll talk about these movements in the subsequent slides. Pupillary reaction is also important because if there is absence or defect of direct light reflex in one eye, it may indicate impaired vision in that eye, and sometimes divergent type of and sometimes convergent type of strabismus can be there according to the age of presentation. In paralysis of sphincter pupillae, for example, in case of the third nerve palsy involving the pupil, the consensual light reflex will be absent. And if retina and optic nerve is impaired, consensual light reflex will be present. So pupillary reflex can also give some clues for us. Then the media regarding corneal opacity, cataract in the lens, similarly the vitreous related problems, and retina and optic nerve pathology should also be ruled out. And then refraction is very important, and cycloplegic refraction must be done in case of the early child, and cycloplegic and mydriatic preferred is cyclopentolate 1%. If in case of infants and above 6 years, 0.5% of cyclopentolate can be used. And in case of infants, even atropine 1% drops or ointment can be alternative, but as it is long acting, it may cause some type of difficulty after 10, even up to 2 weeks. Then comes the test for stereopsis by titmus fly. It can detect 40 second of arc up to 40 second of arc. And normally we know 60 second of arc is normal. And TNO, Lang, even 550 second of arc we can see with Lang, Frisbee, and synoptophore can be used to test stereopsis. Constant strabismus, always stereopsis is absent, but in case of intermittent strabismus we can get the stereopsis present, so it is very important. Now we'll briefly talk about evaluation of sensory state. Word 4 dot test is one of the tests where a patient wear red glass in right eye and green in left eye and tested for both near and distance. Patient will use a box with 4 lights with 1 red, 2 green, and 1 white light. And the interpretation done will be if 4 lights are seen, either eyes are orthotropic, or if there is abnormal retinal correspondence, also they can see 4 lights. But if only 2 red lights are seen, then left eye is suppressed. If 3 green lights are seen, right eye is suppressed. If 2 red and 3 green lights are seen, then patient is having diplopia. And if patient reports green and red light alternate, then there is alternate suppression. Similarly, Bagolini striated glass, which consists of fine striation, which converts source of light into line. And the lenses are placed in 45 and 135 degree perpendicular to each other. And when patient looks through that glass, a patient will see 2 lines crossed. And on the basis of what patient is seeing, we can interpret like if in case of aligned orthotropic eye and abnormal retinal correspondence, patient will see X crossed line. Whereas if 2 lines are separated, then patient is having diplopia. And if 1 line is seen one at a time, there is suppression or simultaneous perception. And if central, there is some gap, then patient is having central suppression scotoma, for example, in case of monofixation syndrome. So again, we have different type of tests like Maddox rod test, which consists of multiple cylinder, red glass, which convert appearance of white spot of light into red streak. Optical properties of rods cause the streak of light to be at an angle of 90 degrees to the long axis of rods. So to measure horizontal deviation for distance with left eye fixing, Maddox rod is placed with the groups horizontal before right eye. The image of light appears as a vertical red line. If orthophoria is there, the line has to pass directly through spotlight seen with left eye. If exophoria, then line of light appears to the left of spotlight. In isophoria, to the right of spotlight. This Maddox rod test can be used to measure even the prism diopter, the deviation we can measure with that. And for vertical, we have to place the groups vertically, and we can see if red line is below the spot line seen, then it is right hyperphoria. So here we can see the The Maddox rod has been kept on right eye, horizontally placed rod. Patient is seeing vertical red line, and left eye is the put point, and the line is on the same. That is the orthotropic state, and exophoria, isophoria we can see here. So apart from them, synoptophore is one of the very often used instrument both for diagnostic and treatment purposes. And with synoptophore, we can assess the strabismus, we can quantify the binocular vision, it can detect suppression, abnormal retinal correspondence. Usually it consists of 6.5 diopters of lens on the both eyepiece, which is set for 6-meter distance optically. And pictures are inserted in slide carrier situated at the outer end of each tube. It can measure horizontal, vertical, and even torsional misalignment. So the synoptophore is used to test the grades of binocular vision also. So simultaneous perception first grade, where is tested by introducing two dissimilar but not mutually antagonistic picture, such as bird and a case. And if two pictures cannot be seen simultaneously, then either suppression or amblyopia is present. A second grade is fusion. It implies the ability of two eyes to produce composite picture from two similar pictures, each of which is incomplete in small details. And third grade is stereopsis. It is ability to see depth by superimposing two pictures slightly from two different angles. Now we'll briefly talk about the evaluation of motor state. Ocular movements can be doxon, uniocular movement, and binocular movement can be burgence and vergence. For doxon movement, each eye is tested one at a time with pen or pen torch, and adduction, abduction, supraduction, infraduction is tested. And if there is the movement is not complete, then we can denote 0 is full movement, whereas -1 to -4 to denote increasing degree of underaction. Vergence are binocular movement and conjugate. It's tested with the help of pen and painters. 6 cardinal gauge of movements where prime mover of one muscle each of the eye, and we can see here in dextroversion we are testing right lateral rectus muscle and left eye at the same time left middle rectus. In dextro elevation, right superior rectus for left eye is inferior oblique. So in this way, all 12 extraocular muscles can be tested with these 6 cardinal gauge of movements. Then we look for near point of convergence. Near point of convergence is the point where the patient can maintain fixation. It can be measured with Royal Air Force rule, and normally it should be 10 centimeter. Similarly, near point of accommodation, again, it's tested with Royal Air Force rule. Patient fixate a line of print which is slowly moved towards patient until it becomes blurred, and where it blurring is seen, and that point is called near point of accommodation. At the age of 20 years, it is around 8 centimeter. In 50 years, it becomes 46 centimeters. Then accommodation convergence by accommodation ratio is important. It is defined as amount of convergence measured in prism diopter per unit of diopter change in accommodation. So there are several methods to measure AC by A ratio. I have mentioned here 2. The gradient method, where change in deviation of prism diopter per change in lens power is measured. And heterophoria method is distance near relationship, where distance and near deviations difference is considered. If patient is more exotropic or less isotropic at near, too little convergence or low AC by A ratio is present. In accommodative isotropia, an increase of isotropia of 10 prism diopter or more from distance to near is considered a high AC by A ratio. Similarly, we have to test for fusional amplitudes, which measures the efficacy of disjunctive movements. It can be tested with the help of prism and with the help of synoptophore also. Normally, the convergence is 15 to 20 for distance and 25 prism diopter for near. For divergence, it is 6 to 10 for distance and 12 for distance. So then comes cover test, uncover, and alternate cover test. So cover test, it is for testing tropias, and on-cover test for phorias, and alternate cover test is used for both tropia and phorias. And for cover test, one eye is occluded. Usually the undeviated fixating eye is occluded, and the movement of deviated eye is seen if it comes from out to in. Patient is having exotropia. So similarly, we interpret. In on-cover test, patient fixed at distance target, and examiners covers right eye, and after a few seconds removes the cover and see the movement. If there is no movement, patient is orthophoric. If there is adduction of right eye, then exophoria, and the same is true for up and down. Alternate cover test, it is every 2 seconds covering right eye and left eye and alternating for several times, and the movement is seen, and if there is no movement, heterophoric. If there is movement and manifest squint is differentiate. And other tests are like forced Dodson test, which is used to differentiate between paralytic and restrictive type of strabismus. Similarly, we have force generation test, where we can again differentiate between the paralytic and the restrictive type of strabismus. Then the measurement of deviation, there are several methods. Horsburgh test is a rough estimation test, where we can see if the reflex is at the limbus, it is 45 degree, and pupillary margin is 15 degree, and in between is 30 degree. So it is very rough estimation, and 1 degree, 1 millimeter is equals to 7 degree and is equals to 15 prism diopter. So Krimsky test is done with the prism keeping in the normal eye and making abnormal eye straight. And prism cover test, with the prism, with occluder, it has to be alternately, the occluder is moved from one eye to next eye, and we will make the eye align with no movement, and that becomes the prism deviation the patient is having. Now we'll briefly talk about the treatment part of strabismus. We have briefly talk about the evaluation. The aim of treatment of strabismus is to detect, exclude, firstly, any ocular or neurological disease. For example, in case of acute strabismus in childhood, we always should rule out intraocular space occupying lesion, because there can be, if acute onset, always this is mandatory. And to maintain, restore optimal visual acuity in each eye, and to have binocular single vision, always not perfect, subnormal binocular single vision, to restore appropriate ocular alignment, to eliminate double vision, to correct significant compensatory head posture, and to improve binocular visual field in case of esotropia. Now, treatment can be of two types: non-surgical treatment and surgical treatment. Non-surgical treatment, again, we can list as optical treatment, patching, orthoptic exercises, and pharmacological treatment. Firstly, any ocular or So briefly, we'll talk about optical treatment comprised of lens and prism use, spectacles, lenses, as well as giving the patient the best visual acuity possible. It may help in control and correction of strabismus. Therefore, it is very important prior to starting any other form of therapy, such as surgery, to ensure that the patient is wearing the correct prescription. So spherical lenses induce relaxation or
Excuse me,
exertion.
Dr. Kabindra.
Yes.
Sir, can you please give your presentation slide full of screen?
It is. It is the. Oh, okay. I have to do this. Now it's okay.
Yes, doctor. Yes.
Just a minute. So, so we're talking about lenses. The use. The principle of lens is it cause either relaxation by convex lens and exertion by concave lens. So by making changes in accommodation, convergence is also changed. So this is the principle for use of lens. And lens used in accommodative esotropia is one of the most important in young patients. We should do cycloplegic refraction and should prescribe the hypermetropic full correction for the patient. Sometimes the second time again cycloplegic refraction is needed to get the all hypermetropic component. And once the hypermetropia has been corrected, patient may return fully controlled at near and distance. However, some patients may return with no change in deviation at near or distance. In that case, they have non-accommodative type of deviation. And also there sometimes some part is corrected with glass and some part remaining. And at that time, partially accommodative deviation we have to think about. And so we have to remember two cycloplegic refraction that should not be difference in 0.5 to get the exact refraction. In case of high AC by A ratio, a patient who returns fully controlled with orthophoria, heterophoria, or monofixation at distance, but still has significant ISO deviation at near, and a patient who has no significant hypermetropia, but an ISO deviation with significant distance near disparity, near is greater than distance, then they may have high AC by A ratio, and these patients are treated with bifocal spectacles. If fusion cannot be obtained with bifocal, the bifocal should not be given. Gradually over time, the aim is to reduce the bifocal strength either with or without help of divergence exercises and eventually eliminate them by the age of 10. One of the fears of treating with bifocals is the risk of premature presbyopia. And some patients may lose fusion through the bifocal over time, and others may not develop fusion. So in this case, it is important to realize that although bifocal is reducing the angle, it is not producing any fusion, and there is no, it is not serving a purpose. So if a patient had an exodeviation with a full plus or in hypermetrop who is exotropic, it may not be necessary to give full plus. On the other hand, if myopic isodeviation, it may be necessary to slightly undercorrect the refractive error, though this may not be well tolerated. In case of intermittent exotropia, minus lenses have been described as a non-surgical method of treatment. The patient is over-minused and therefore needs to accommodate to see clearly, and the associated accommodative convergence aid in control of deviation. Secondary esotropia after surgery, if some part is remaining, and we may need small the convex lenses. And also, if any hypermetropia present has not been corrected before, or if bifocals, if esotropia is only at near. Now we'll briefly talk about use of prisms. Prism improves fusional amplitudes. Base out and base in prism Base out is used for convergence and base in for divergence. The prism, they are also used in intermittent exotropia and also in surgical over and under correction, after surgical over and under correction if some part are remaining. And also in case of the acute, the paralytic type of strabismus, when patients are waiting for spontaneous recovery before going to surgery to overcome diplopia, we can use prism. It can be Fresnel prism, but we have to know that the Fresnel prism, every 10 diopter cause one line of vision blurring. So if a high prism is there, it may not be practical sometimes. Small angle committant deviation can be treated either with prism ground into spectacles or with Fresnel prisms. Prism are preferred over surgery in case of small deviations where patient refuses surgery and patient who have changing condition like grapes and symptoms producing heterophorias. Coming to the patching for strabismus, patching helps to improve amblyopia, but not strabismus itself. It is important because before going for surgery, amblyopia need to be treated. A study suggested that in intermittent exotropia, alternate occlusion therapy can improve the sensory status and strengthen the fusional amplitudes, but does not improve the deviation angle and therefore is useful to postpone surgery in young children and may improve surgical outcome. So I will just briefly talk about orthoptic exercises. Orthoptic exercises have become increasingly diagnostic and less therapeutic over the years. The purpose of orthoptic exercises are to eliminate suppression, to control deviation, to extend fusional amplitudes, and to improve near point of convergence. The criteria for orthoptic exercises are: examiner must be certain that normal sensory and motor fusion can be achieved. After 8, 9, 10 years, it's very difficult. Visual acuity is equal or nearly equal. Patient must be able to complete follow-up. Pathological cause should be excluded, and patient must be cooperative and able to understand and perform the exercises. And symptoms must be attributable to deviation and not other causes. So sometimes it can cause irretraceable diplopia and even accommodative spasm if over enthusiastic convergence exercise or by promoting control of large exodeviation. Orthoptic exercises are used in case of convergence insufficiency, decompensated exophoria, and intermittent exotropia. The convergence insufficiency, the amplitude of fusional vergence mechanism may be increased by exercises. This treatment works best for near fusional convergence, particularly for the relief of symptoms of asthenopia. The order of treatment should be amblyopia treatment first, followed by anti-suppression therapy, followed by diplopia training, and then amplitude improvement. The synaptophore is one of the orthoptic exercise instrument which is used in case of orthoptic exercises. And similarly, pencil push-up exercises can also be easy method to be done at home. It is done is less complicated, good for young children. It can be start where fusion possible. Target is moved towards nose until diplopic and move target back to fusion and then forward. So if suppression, use red filter. Now I will briefly talk about drugs, pharmacological treatment for strabismus. Miotics, cycloplegics, and botulinum toxin has been used in case of strabismus. Miotics, they can cause accommodation is brought about by direct action of ciliary muscle, as we know. Therefore, without synkinesis of convergence, while increased depth of focus reduces need for accommodation, and uses are for short-term therapy to help a patient to work without glasses, to convert tropia to phoria so that divergence exercise can be taught, take place of glasses during athletic events given to small babies who will not wear glasses. For accommodative esotropia, ecotyphate and isofluorophate are the two common anticholinergics used in treatment of accommodative esotropia. They allow acetylcholine to accumulate at cholinergic receptors at ciliary muscle, thereby facilitating accommodation. Pilocarpine can also be used, but it is short acting, so it needs several times of installation. In case of surgical over and under correction, also diuretics have been used. In case of ocular myasthenia, pyridostigmine, physostigmine, neostigmine, the anticholinesterase drugs has been used, and botulinum toxin has been used to make paralyzed in case of 6-nerve palsy in middle rectus. If botulinum toxin is injected, after 1 month of, if there is no recovery after 1 month of palsy, it can be given. And similarly, in case of infantile esotropia and intermittent exotropia, also there has been evidence where people are using botulinum toxin. Now, I will be briefly talking about the common strabismus in pediatric population, which we most of the time encounter in our pediatric OPD. Acquired esotropia, accommodative, partially accommodative, or non-accommodative types. Infantile esotropia, intermittent exotropia, congenital superior oblique palsy, Duane's retraction syndrome, Brown's syndrome, sometimes double elevator palsy, Mobius syndrome, and even sixth and third nerve palsy also we can encounter in our OPD. I will be briefly talking about accommodative esotropia. We have already talked. The treatment is full cycloplegic refraction and prescribe hyperopic glass. And if sometimes with glass only there is no correction, then only we go for surgery. Usually, if bilateral equal vision, then bimedial recession is done, and if one eye is amblyopic, then recession resection is done in case of. Then this is one of the picture who visited our OPD. Without glass, the patient is isotropic, and with glass, it is eyes looks aligned. In case of partially accommodative esotropia, full correction after cyclorefraction and remaining part is corrected surgically. In case of non-accommodative esotropia, it needs surgery. This is one of the child who visited our OPD with large angle of esotropia, around 80-90 prism diopter, and the first step surgery was bilateral recession, was large 9 mm recession by both eye, and with that also patient was not corrected. So after 3 months, again operated with bimedial resection, and eye is finally aligned. So the surgical treatment goal is to attain peripheral vision with fusion with fusional vergence amplitude sufficient to maintain alignment of the eyes, comfortable binocular vision to enable the patient to perform visual tasks without asthenopia, and improve cosmetic appearance. When to operate? So strabismus surgery is appropriate when all non-surgical methods to reduce the visual axis deviation have failed, and if patient systemically stable for the procedure and the anesthesia, general anesthesia is required, as we know, so patients should be fit for anesthesia, and patient and parents understand the goal and the limitation of planned surgery. Preparation of patient for surgery, appropriate psychological preparation, explanation of post-operative discomfort, possibility of under and overcorrection should be explained, as I have shown in previous picture that there is need of second surgery. So in surgery, there are two procedures. One is weakening and one is strengthening. So what are the weakening procedures? And we have to know that weakening procedure has a greater effect than strengthening procedure. In weakening procedure, either we can go recession of muscle, where muscle is disinserted and sutured behind the insertion site. Myotomy is making elongation of muscle by doing several cuts. And disinsertion is also called myectomy. We just disinsert from inserted side, and we do not need to suture. We can just leave that. For example, in case of +4 inferior oblique overaction, we can do myectomy, inferior oblique disinsertion. Posterior fixation of muscle, also called Faden procedure, where non-absorbable suture is applied 10 to 12 millimeter behind the insertion site, so that that part will have no action for the required action. And the tenotomy and tenectomy are also the procedure where we can produce some weakening effect. This picture is showing the insertion part. The muscle has been disinserted, and again it has been sutured behind 5 millimeter from the insertion site. So this is recession. Muscle strengthening is resection, where a part of muscle is sacrificed. Also, tockling is a strengthening procedure where same muscle is overlapped. For example, in case of superior oblique palsy, the tockling of superior oblique muscle can be done. Advancement is after previous surgery. If we have to bring muscle towards the insertion site, at that time this procedure is called advancement. This is resection of horizontal muscle, where part of muscle, first the muscle has been disinserted and part of muscle has been cut, and that muscle again inserted at the sutured at the insertion site. Adjustable sutures are used sometimes when there is precise outcome is necessary with one operation, because we always know that despite of having several datas to do how much to recess, how much to resect, always there is surprise after surgery. And if we need precise outcome, then adjustable sutures can be used. And if a conventional approach is unpredictable, in case of 6-knob palsy, in case of adult exotropia, in case of 3rd-knob palsy, and reoperation with scarring, we need to do adjustable suture, so that after surgery in post-op day or the same day after recovery from anesthesia, we can adjust the amount of surgery. The contraindication is too young patient and who is uncooperative. This is a chart showing usual amount of recession and resection we perform. For middle rectus, recession 5 mm, for resect 8 to 10. And these are the rough estimation. But usually we do not operate 6 to 7 millimeter, more than 6 to 7 for middle rectus and more than 10 for lateral rectus. For superior and inferior rectus is around 5. For inferior oblique up to 8 to 12, and superior oblique can be talk up to 12 to 14. Now, I think we are not having so much time, so I will briefly cover few the strabismus, where surgery is the treatment modalities. So infantile esotropia, usually that is constant by 6 months of age, and 8% of children are esotropic. It is this data taken from one of the study, and the cause is unknown. So presenting feature can be good visual acuity in both eye with binocular vision absent, and refractive error usually not found, large angle of esotropia more than 30 prism diopter with cross fixation, nystagmus can be there, inferior oblique overaction can be there, and dissociated vertical deviation can be there. The surgical procedure is bilateral medial rectus recession, both eye middle rectus recession. And if one eye is amblyopic, then unilateral middle rectus recession and lateral rectus recession can be done with or without inferior oblique recession, depends upon inferior oblique overaction is present or not. Outcome in eyes aligned within 10 prism diopters of orthophoria, up to 1/3 of patients develop subnormal binocular vision. And some evidence suggests that early surgery is associated with better binocular outcome. So this is one of the conditions where surgery should be done as early as possible. This is one of the picture we did in Lumina Institute, infantile esotropia, but it presented at the 5 years of age. But despite of that, we did bimedial recession and the eyes looks orthotropic. So exotropia is the next condition. It can be congenital, it can be intermittent. In intermittent also, convergence insufficiency, divergence axis, and basic type also. And depending upon the type of intermittent exotropia, the surgery are different. This is one of the pictures showing intermittent exotropia. Sometimes eye looks straight, and if fusion is broken, then the eyes exo. So management is myopic spectacles may improve in some cases to some extent, and surgery is needed in most of the patient by 5 years. Bilateral lateral rectus recession is done for divergence axis type, bilateral middle rectus resection for convergence insufficiency, and for basic type unilateral resect can be done. And while doing resection, always resection should be done first, and then only resection we used to do. So superior oblique palsy is one of the next condition. It can be unilateral or bilateral. It can be congenital, sometimes acquired. An indication of surgery is if there is diplopia and abnormal head posture. Here, inferior oblique weakening or superior oblique talking can be done as a treatment. Here, this is, I just kept this picture to show the superior oblique palsy, PARC 3-step test. In the third Belchowski test, we can see here the patient is in left. The last picture looks orthotropic, and the right one, there is much more hypertropia in the third step. If bilateral, then X cyclotorsion should be first corrected by Harada-Ito procedure. It involves splitting and anterior lateral transposition of superior oblique tendon. Then any associated vertical deviation can be corrected at the same procedure or subsequently. This is a superior oblique tendon and splitting superior oblique and anterior the half splitting, and it has been inserted towards the middle rectus. Next, Duane's retraction syndrome. This can be of 3 types. And type 1, there is abduction deficit. Type 2 is adduction deficit, and type 3 both can be present. And depending upon the condition, the recession is always the procedure of choice for Duane retraction syndrome. Lateral rectus recession for type 1, middle rectus recession for type 2, and for type 3, it depends upon the type of deviation. So Brown syndrome is in the adduction and elevation, there is deficit. If there is no much problem, we can live. But if there is hypotropia, then surgery is required. Inferior oblique recession or superior oblique tenotomy is procedure of choice. If acquired cases, steroid can benefit this patient. So we missed about steroid in the medical treatment in previous slides, because steroid are we use in case of third nerve, even fourth nerve case, even in the Brown syndrome, the acute case, steroid has role. We can, before giving steroid, we have to do investigation if any underlying medical condition, and then steroid can be used one course for this strabismus. Now there are many complications during preoperative also oculocardial reflex, during surgery, muscle can be lost, globe can be perforated. After surgery, nausea, vomiting is usually common, and undercorrection, overcorrection, red eye, anterior segment ischemia, diplopia, and in long term, there can be foreign body granuloma, scarring, Delen formation, and palpebral fissure height changes. So after surgery, we used to give steroid and antibiotic for 6 weeks. So in this way, briefly, I have covered my today's topic regarding the management of strabismus in pediatric population. Now I will be happy to have any question, then I will be happy to answer. Thank you.
Thank you, sir, for this informative session. Also, thanks to all the participants for your patience. Now we are about to begin our discussion session. If you have any questions, please write on the chat box. Let me check the questions you have raised. Sir, here is the few questions. Here is one question by Ramji Saha. Uh, how recession of muscle happen during surgery?
Okay, so during surgery, uh, before doing recession, the most important thing is we have to calculate how much deviation is there, and after we know the deviation, we will usually consider how much to recess, how much to resect, and we have to recess first and then resection. So recession, yeah, if we have time, I can briefly, in 2-3 minutes, I can show a small video. Is it possible, Prinaji?
Sure, sir.
Okay, because I will talk in between also, and I will show this video. This is the video. We did this surgery. Okay, here, this is a strabismus surgery. I'm doing a force reduction test to rule out any restrictive restriction in any part or not. So I did all 6 motion, and this is a fornix-based incision, just inside that conjunctiva peritomy. And now this is exposing tenons, a tenons cap, from where we can send muscle hook. So making a little bit bigger, because this is a case of third palsy. I have to do large recession, so I did big peritomy here. So this is lateral rectus muscle exposing tenons. This is lateral rectus muscle. So after cutting conjunctiva, tenons, then we find the muscle and the insertion of this muscle. After that, we used to secure this muscle. We use Vicryl 6O, which is absorbable synthetic type of the suture. And after securing this muscle, we do this insertion from the muscle insertion site, and that muscle is reinserted posteriorly. So how much we go posterior, it depends upon, it is already sutured at the back of the insertion, and this conjunctiva is again sutured. We have to cover with conjunctiva again. So this is recession. So amount of recession and resection, it depends upon the amount of deviation. For example, I roughly say if 35 prism diopter exotropia is there, then we multiply 5 into 7, it becomes 35. It's very rough. It's just to show 7 mm recession and 5 mm resection can correct more or less 35 prism diopter of exotropia. And this is, I'm doing resection. Again, all same procedure, muscle exposed, and then we have to secure muscle. Then part of muscle I'm going to cut here, and that is resection. And the sutured part of this muscle is sutured at the insertion site, and it becomes resection. So as I previously mentioned, that recession is always done first, then only resection. And the amount of recession and resection is always depends upon the degree of deviation. And next important thing is always the middle rectus surgery is lesser amount than lateral rectus. Lateral rectus we can go up to 10 millimeter, but middle rectus we can go up to 6.5, not more than 7 mm. So for exotropia surgery, always we find this is I'm inserting the muscle at again insertion site. So always we if 7.5 is mentioned, we have to know that this is exotropia surgery because lateral rectus muscle is always bigger. If 5.7 we mentioned somewhere, then we have to know that it is like for esotropia surgery because middle rectus is always lesser than lateral rectus. And we have to know that the effect of lateral rectus surgery is 1 millimeter produce 2 prism diopter changes, whereas middle rectus 1 millimeter surgery changes about 3 prism diopter changes. And we have to add again the both side and part of 1/3 of both muscle effect again we have to add. So these are the some of the tips, how we do surgery.
Thank you, sir.
Okay.
Here is another question by Ramji Shah. In case of strabismus amblyopia, can't we give priority to the surgery to treat amblyopia?
Once again, can you repeat the question?
Sure, sir. In case of strabismus amblyopia, can't we give priority to the surgery to treat amblyopia?
Yes, but for amblyopia, always we go first. We have to correct refractive error, and then we have to go stepwise treatment like patching, then orthoptics, and then surgery. And definitely, if refractive error has been already uh, corrected, despite of that, patching will have very less effect, we know. So after correcting refractive error for certain time, and then we can definitely go for surgery. That is also one of the treatment modalities for amblyopia. Yes.
Thank you, sir. Here is another question by Ananta Paul. What can be the treatment modalities for intermittent XT with moderate and high hypermetropia?
Uh, for hyper intermittent exotropia with
Moderate and high hypermetropia.
okay, so if there is moderate to high hypermetropia, uh, we have to give plus glass, which will make again eye in, eye out, and intermittent exotropia is already there. So this can be a very difficult situation. But what we have to do is refraction. Uh, we have to the visual acuity is always the foremost, and then only the binocular single vision or the alignment. So first we have to correct the visual acuity, and then uh, the remaining part, if there is, with that refractive error correction, if the amount of deviation is going to increase, and we have to consider about the age also, because hyperopic very early, the according to the age it can change into myopic. So we have to consider for that also. If the patient is already 8 years 9 years and above, then the much myopic changes uh, we cannot expect. In that cost we have to correct with glass, and the whole amount of the exotropia we have to correct with surgery. Okay.
Yes, sir. We have another question. Hmm.
Yes, please.
Two muscle surgeries, three muscle surgeries should be performed on what? It depends on, sir, how much we can do, how we know.
Uh, it depends upon two parameter. One is if there is more than 65 prism diopter exo or esotropia, we are sure that only two muscle surgery is not going to uh, cover all exo or esotropia. So in that case, we have to go for three muscle surgery. And the important part is if three muscle surgery for two different eyes is no problem, but same eye, if we operate three muscle at the same time, it is risk factor for developing anterior segment ischemia. But if two muscle for right eye and one muscle for left eye, definitely we can go. Even sometimes we have to go for four muscle surgery also if there is big enough, like 100 prism diopter like that.
Uh,
Okay, thank you.
if you have any questions, you can write on the chat box, please. Sir, I have one question. Uh, what would be the treatment modalities if one has intermittent strabismus but the vision is not affected, and the vision is not affected, he has normal vision? Intermittent
Okay, then
strabismus.
we have to think about, yeah, we have to think about for intermittent exotropia. What has been showed is if it is present very brief amount of time, when patient is fatigued or ill or defocused, very less often. If there is exotropia, we can just leave that, because they are having binocular vision, straight eyes most of the time. But if half waking hour, more than half waking hour, there is exotropia, then this is time to intervene for surgery. And above 5 years, the patient is not going to improve, and we have to think for surgery.
Thank you, sir. Here is another
Sir,
question.
I have one question. So, after doing if we did a surgery and still there is a residual uh, mm, tropia, if we had already did the surgery, yeah, and still there is a residual after the surgery. So, what can we do with the surgery? It could be like treated by the other methods.
Yeah, thank you for the question. Yes, definitely. If our goal is to get after surgery less than 10 prism diopter is expected, but if it is more than 10 prism diopter, and we can uh, prescribe some type of plus or minus glass to align also, that can be some type of refractive correction. But despite of that, if patient is not satisfied and having a problem, then we can do re-surgery in same eye also. And also next eye surgery can have effect on the deviated eye. So there are many options. But if very small angle is left, then we can prescribe glass, or without glass also very unnoticed type of residual or consecutive ESO and exo also can be left as such also.
Sir, here is another question by Dr. Bikram Thapa. What is the maximum LR resection and MR resection we can do?
For middle rectus, maximum 7 resection we can do. For lateral rectus, 10 millimeter of resection is maximum. But in case of third nerve palsy, sometimes we even go resection up to 12, 13, 14 millimeter also, because of we do supramax, and sometimes otherwise the usually performed surgery is about 7 for middle rectus, both resection, and 10 for lateral rectus. And we cannot go more than 1/3 of the length of the muscle size, that is 40 So where at 2/3 and 1/3 junction, the nerve is supposed to innervate muscle. So that is the cause we cannot. And next one is, if we go beyond equator, the surgical effect of that muscle will be very minimal. So we do not go beyond equator. Yes, Aprina ji, are you hearing me?
Hello, Aparna. I guess you are. Can you please unmute yourself? All right. I guess same problem with the technical internet. Okay, no issues. So I guess I've answered most of the question. So I would like to request any, if you have any question, you can join with the and direct the question. And if you have any feedback for our platform, so Doctor, it's
Yes. So, is this the class today end, or do we have any more questions?
Excuse me, sir.
Yes.
In congenital cases, why treatment is not affected in Bowman syndrome, Brown syndrome?
In Brown syndrome, if usually Brown syndrome is in adduction and elevation, there is because of superior oblique tendon, sometimes it is called superior oblique tendon syndrome also. Patient cannot look up in adduction position only. But in primary gaze, if patient is comfortable, because most of the time we are using for the primary position, and for dextro version and dextro levo version also, patient is having no problem. In depression also no problem, only problem in adduction elevation. So this can be left. But if there is head posture, hypotropia is there, and at that cost, we have to go for surgery.
Thank you, sir, so much.
Welcome.
okay, Doctor. I guess we have answered many of the question. Yes, are you there? Aprina,
Yeah.
Dr. Aprina, are you there?
Yes, sir.
Okay. Okay. If it is good, you can continue.
I guess we have answered most of the queries. And considering the time limits, I here announce the closure of the discussion session. Before ending today's session, I would like to request Dr. Kabindra Bajracharya to have few words about the webinar.
Okay, I'm very happy, thankful to Mero Eyes.
Mero Eye
This
Foundation, sir.
Mero Eye Foundation, who has been doing this type of academic activities through online classes. Despite of COVID time, we are in lockdown position, but we are doing our study. Our study has not been stopped with because of this type of platform. And this is not only national, international, everywhere. It can be heard, it can be seen. We can share our knowledge, because today I am presenting. That does not mean that I am the perfect one. I'm also learning. Because of this presentation, I have to go through many research work, text. So this is time to learn for me also, and I could share my knowledge, what I have done, I perform, I'm doing. And so this type of platform you have created, I'm very much grateful to this organizer and all the participants. Thank you so much. You all bear me for about 1.5 hour, and I will be happy to be with you in coming days also. If any thing I can learn from you or I can share from my side. Thank you so much, Aprina ji.
Thank you, sir. I would like to express my sincere gratitude towards the presenter Kabindra Bajracharya and all the attendees. Also, I would like to appreciate all the helping hands for the iTalk programs. Herewith, I am ending the today's session, requesting
Just,
all of you to
I
drop
just
your review.
I want to say two words because I got this platform through Ananta, one of our optometry student, is doing very good job. And I'm here on behalf of Lumini Eye Institute and Research Center. So I must thank this institute and Ananta ji and Kapil ji and Opinjan ji, along with all the participants. Thank you so much.
Thank you so much, sir. Herewith, I'm ending the today's session, requesting all of you to drop your reviews and feedbacks. Stay safe and thank you.